So good afternoon, everybody. Today we'll start with treatment guidelines for heart failure. So basically, what is heart failure? So heart failure, it is the inefficiency of the heart to pump blood properly. So because of this, the body is not getting enough blood. So that is called heart failure. Okay. So what is the symptoms of heart failure? What is the common symptoms you experience? Chest pain, shortness of breath, edema, wheezing, and all that. Okay. So first we'll see what are the stages of heart failure. So we have 4 stages of heart failure. So first it is stage A, that is at risk. Stage B, that is called as pre-heart failure stage. Stage C, that is symptomatic heart failure, that is HFrEF. It's divided into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And it is stage D, that is acute decompensated heart failure. So basically, what is stage A? They're at risk. That is, they do not have any side effects of, they do not have any signs and symptoms of heart failure, but they are at the risk of developing heart failure at any stage. Okay, so that is called as basically at risk. That is stage A. So example can be patients who's a known case of hypertension, who's a known case of diabetes mellitus, who's known case of any cardiovascular disorders like MI, angina, and all that. So they can develop heart failure in near future. So that is called as at risk. Next, stage B is pre-heart failure. So here they do not have any. Okay, 1 minute. And in stage A, all their biomarkers are found to be normal. All the trope levels, NT-proBNP, CKMP levels, everything is found to be normal. So that is the thing with stage A. Next, coming to stage B, that is pre-heart failure. So here again, they do not have any signs and symptoms of heart failure. They do not have much difference in the like cardiac markers. There is no much difference, but they have some structural changes, like they have structural heart diseases or valvular heart diseases. So they have like they're highly prone to develop heart failure at any nearby time. So that is called as pre-heart failure. Next is symptomatic heart failure. They have developed the signs and symptoms of heart failure. Okay, all the shortness of breath and all, chest pain and all, they have. So again, symptomatic heart failure is divided into different types based upon the ejection fraction. I'll come to that. So HFrEF is heart failure with reduced ejection fraction, and HFpEF is heart failure with preserved ejection fraction. That is symptomatic heart failure is divided into 2 types. That is HFrEF and HFpEF. And finally, stage D is acute decompensated heart failure. Here they have signs and symptoms, they have elevated biomarkers and all that. Whereas when it comes to stage D, they have signs and symptoms, elevated biomarkers, and it interferes with their daily life. So they have recurrent hospital admissions. So that is called as acute decompensated heart failure. Okay. So now I'll discuss about stage C and stage D mainly. Okay. So stage C, that is symptoms. They have heart failure. Okay. So how can you classify them into different types of heart failure? It is based upon ejection fraction. Okay. So can you tell me what is ejection fraction? Okay, so it is a percentage of the blood that the left ventricles pump out of the blood at pumps out of the heart at 1 heartbeat. So that is called as ejection fraction. Okay, so what is the normal ejection fraction? 60. Greater than 60 and above is called as normal ejection fraction. So if the patient is having ejection fraction less than 40%, less than or equal to 40%, they are classified as heart failure with reduced ejection fraction. If the if the ejection fraction is greater than 50%, it is called as heart failure with preserved ejection fraction, because that means they have signs and symptoms of heart failure, but the ejection fraction, that is the pumping, is good. So that is called as preserved ejection fraction. Whereas there is reduced pumping, that is there is less amount of blood being pumped out of the left ventricles, that is called as reduced ejection fraction. And there is another 2, that is heart failure with improved ejection fraction and heart failure with mild reduction in ejection fraction. Okay, so if they have just remember, greater than 40 it is okay, less than 40 it is heart failure with reduced ejection fraction, greater than 50 it is preserved ejection fraction. So between 40 and 50 there is some values, right? 41 to 49. So that is called as mildly reduced ejection fraction. Okay, that is called as HFmef. Okay, just tell mild reduction in ejection fraction. And something called as heart failure with improved ejection fraction. This is when the previous ejection fraction is less than or equal to 40%, and when the follow-up is greater than 40%, they can be classified as this. Okay. So this is classification based on ejection fraction. That is, the symptomatic patients who comes to you with signs and symptoms of heart failure, you can divide them based on this. So how can you know the ejection fraction? You will get it through your echo. Okay. Next, coming to diagnosis, basically there is no such diagnostic guidelines as such for heart failure. Basically, you'll classify, you'll finalize them as heart failure patients based on the clinical symptoms. So you have some add-on tests which you can do to confirm that it is heart failure. So one, it is chest X-ray. So in chest X-ray, you will find that they'll have cardiomegaly. They'll have then they'll have pulmonary edema. You can identify through chest X-ray. Then bilateral pleural effusion, and all this you can identify through chest X-ray. Next is BNP, that is brain natriuretic peptides. So brain natriuretic peptides is something which has been released by your heart muscles. So this is being released from your heart muscles when the heart is under stress. At normal conditions, this is not released. When your heart is under stress, this brain natriuretic peptides has been released into your bloodstream, and on serial evaluation of that, you'll identify that the patient is known to have heart failure. Okay, so that is one method. And again, you BNP levels, that is BNP levels has been cleaved and it has been converted, and you'll know you can do the test called as the NT-proBNP. Have you heard that? It's from this. Okay, so and again, you can't use NT-proBNP as a diagnostic test. It is used for it is used as a prognostic marker. That is, it is used to check the effect of the treatment. It is not, you can't confirm that as a diagnosis, because for example, in case of any atrial fibrillation, in case of CKD, there are chances that this can go high. So that is why you can't take that as a diagnostic marker. Okay, so just because NT-proBNP is high, you can't confirm that as heart failure. Okay. Next is echo. Again, echo helps you to identify all those ejection fraction and all that. So that is how echo is useful in heart failure. Okay. So now let's just, shortness of breath. Again, you need to classify them based upon, we have a classification called as New York Heart Association, NYHA classification for heart failure. So in class 1, they're classified as class 1 when the shortness of breath is only on extreme exertion. Only when there is extreme exertion, and if they have developed shortness of breath, they're classified as class 1. If they develop shortness of breath or chest pain on moderate exertion, they are class 2. On mild exertion, it is class 3. And at rest, if they're developing shortness of breath or chest pain, they can be classified as class 4 NYHA classification. Okay. Next. Okay. Now we'll look into the RAS mechanism for that to identify about heart failure. So basically, you all know this mechanism, right? When there is decreased perfusion, it is known to trigger the juxtaglomerular cells, and this in turn releases renin. So this renin, what it does is the angiotensinogen, which has been released from the liver, this renin helps to cleave angiotensinogen to angiotensin 1. Then the AC, that is angiotensin converting enzyme, which has been released from the lungs. This helps in the conversion of angiotensin 1 to angiotensin 2. So this angiotensin 2 has got 3 main mechanisms in your body. Okay, first it binds to the receptors of the arterioles. So this in turn is known to cause vasoconstriction. So when there is vasoconstriction, what is going to happen? Increase in the blood pressure. So that is, it is known to cause increase in the total peripheral resistance, which in turn is known to cause blood pressure. Forget that. So increase in the total peripheral resistance is known to cause increase in the afterload. So do you know what is afterload? Yeah. So afterload is the amount of the pressure that the ventricles have to overcome in order to push the blood into the aorta. In order to push the blood into the aorta, the amount of pressure the left ventricle has to undergo, so that is called as afterload. Okay. So when there is increase in afterload, that means your heart has to, imagine you have heart failure. When you have heart failure, there is decreased perfusion. So all this is happening. When there is increased afterload, that means your heart has to extra pump so much. Okay, so that is one reason, that is one mechanism. What happens? That is, there is increase in afterload. Second mechanism, angiotensin 2. It acts on the adrenal gland. So what it does when it acts on the adrenal gland? It releases aldosterone. This aldosterone goes to your kidneys, and it helps and it causes increased absorption of sodium and water. So when there is increased absorption, what happens? There is increase in blood volume. So at normal mechanism, when there is increase in blood volume, it results in increase in blood pressure. We leave that. So when there is increase in blood volume, what it happens is there is that much amount of blood which is going to your heart, which has to again undergo all this same process. So again, this results in increase in end diastolic volume. So when there is increase in end diastolic volume, it causes an increase in the preload. So can you tell me what is preload? Yeah, the measure. So it is the measure. It is a measure of the degree of ventricular stretch prior to the contraction. That is, before when it is going to contract, the degree of ventricular stretch what the heart undergoes, that is called as preload. Okay, so basically it is making a heart work extra. When aldosterone is released, there is increase in preload. When it causes vasoconstriction, there is increase in afterload. Next, there's one more mechanism. This angiotensin 2 goes and stimulates your pituitary gland. So when that is being stimulated, it causes the increase in the release of antidiuretic hormone. So what it does, this goes to your kidneys, and this in turn causes excretion of increased urinary excretion. Okay, so it decreases the urine output, and it causes increase in the sodium reabsorption. Water reabsorption. So when there is increase in water reabsorption, what it causes in turn? It in turn increases the blood volume. So when there is increase in the blood volume, again it causes increase in the end diastolic volume, which results in increase in the preload. Okay. So when you have heart failure, so what and all is happening? There is increase in preload, there is increase in preload and increase in afterload, which is causing a heart to stress extra. So that is why we use all these classes of drugs. That is, we have heart failure drugs has been classified into 4 types. That is, it is not classified, it is based on the order in what to use these drugs. That is why it's classified into 4. So class 1, it is AC inhibitors or ARB inhibitors. In case the patient is not tolerating AC inhibitors, either one you can use, AC or ARBs. It's not both. If the patient is not tolerating ACs, then you can switch the patient to ARBs. Okay. Then the class 1 is beta blockers. Next, class 2 drugs is diuretics. Class 3 is ARNIs, that is angiotensin receptor neprilysin inhibitors, aldosterone antagonists and isolacin, and class 4 is digoxin and dobutamine. So you all know the mechanism. So what does ACE do? What does ACE inhibitor do? Yeah. So it will come and inhibit this enzyme. So because of that, there is no conversion of angiotensin 1 to angiotensin 2. If there is no conversion, there is decrease in afterload, there is decrease in preload. Next, what does ARBs do? Angiotensin receptor blocker. So indirectly it blocks this angiotensin receptor 2 directly. So because of that, all these again is being reduced. Next, what is the function of beta blockers? Yeah, so what beta blockers does is it goes and prevents the attachment of norepinephrine to the beta blocker. So because of that, there is decrease in heart rate. That is one. Second, so it prevents the beta blockers on the SA node. So because of that, your heart rate has been reduced. That is one thing. Second, it attaches on the myocardial cells. So it prevents the beta blockers on the myocardial cells. So because of that, the contraction has been reduced. So because of that, again, when a contraction is, the oxygen demand supply, everything has been maintained and all that. So that is a function of beta blockers in heart failure patients. Next, what does diuretics do? So when there is excretion of sodium and water, okay, we use 2 types of diuretics. That is, one is loop diuretics, one is thiazide diuretics. Okay, thiazide diuretics. So what does loop and thiazide diuretic do? It will prevent the it will decrease the absorption of sodium and water reabsorption. So because of that, there is decrease in the blood volume. So when there is decrease in blood volume, there is decrease in end diastolic volume. So because of that, there is decrease in the preload. So that is about diuretics. Next, what is ARNIs? Angiotensin receptor neprilysin inhibitors. Sacubitril and valsartan. So can you tell me the mechanism of action of that?
They act on BNP and reduces blood volume.
Yeah, correct. So what happens? So you know that BNP has been released from your heart when it is under stress. So what happens is, when BNP is reduced from your heart, this BNP is known to cause, this BNP will inhibit this angiotensin 2 receptor in your body at normal physiological condition. This BNP this brain natriuretic peptide will come and inhibit this angiotensin 2. So we have in our body, we have an enzyme called as neprilysin. So this neprilysin will inhibit this BNP. When this BNP has been inhibited, it doesn't cause the inhibition of angiotensin 2. So when you give this drug, angiotensin receptor neprilysin inhibitor, that will go and inhibit that neprilysin enzyme. So because of that, BNP can continue its action by inhibiting angiotensin 2. Okay. So the example is sacubitril. So it is given in combination with always ARBs, that is valsartan. So that is because you will get dual action. First, it will inhibit this. So anyway, it will inhibit angiotensin 2. When you give ARBs, again it is inhibiting this. So you will get a dual action. So that is why you will give it as combination. Next, aldosterone antagonist, example, can you tell? Spironolactone and eplerenone. So what it does, it comes and inhibits this aldosterone. So because of that, all this function has been inhibited. Next, isolacin. Isolacin is a combination of isosorbate dinitrate plus hydrolysine. So what are these two? These two acts as vasodilators. So what happens? Isosorbin, it acts on your smooth muscles. It acts on the venous smooth muscle cells, whereas hydrolysine acts on the arterial smooth muscles. Okay, so what it does is, these both have the same function, only the site of action is different. Isosorbate is on the venous part, whereas hydrolysine is on the hydralazine is on the arteries. Okay, so what happens is this is known to increase the So what happens is these two drugs will cause the increased effusion of nitric oxide. So this in turn is known to activate something called as guanylate cyclase. So this in turn increases the conversion of GTP to CGAMP. So this in turn is known to cause it will prevent the entry of calcium. So because of that, your contraction has been reduced. There is decreased vasoconstriction and there is increased vasodilation. So both have the same mechanism of action. Isosorbate is on the venous smooth muscles, hydralazine is on the arterial smooth muscles. So that is the only difference. And finally, class 4 is digoxin and dobutamine. Digoxin, it is known to act on the AV node, and because of the heart rate has been reduced. And dobutamine is known to, it is used only in acute decompensant heart failure, that is to stabilize the hypotensive crisis which the patient experiences. So I'll come to the treatment guidelines now. Okay, can you, now a patient is coming to you with at risk stage A. So what is the treatment guidelines you prefer? Yeah, first is lifestyle. So at A, that the patient is in at risk. So first is lifestyle management, that is regular physical exercise, maintain normal body weight, healthy dietary pattern, avoid smoking, alcohol consumption, etc. So, and you'll have to treat the underlying condition. I told you always they'll have comorbidity, so you'll have to treat the underlying condition. So if a patient come to you with hypertension, you'll have to treat, you'll have to maintain optimal control of blood pressure. If a patient comes to you with diabetes mellitus, again treat it. So okay, I'm asking a question. Suppose a patient is coming to you with type 2 diabetes mellitus, and at the same time is having any of the CVD, like any CVD, any cardiovascular disorder. So which agent will you go first? Type 2 diabetes mellitus. Yeah, DAPA will be good because it is known to have better efficiency. It is cardioprotective, so that is why. Next, imagine okay, then if a patient is coming to you with CVD, that is MI or angina, you'll have to give optimal management. Patient who is at risk of heart failure, you'll have to do screening, natriuretic peptide screening. So you'll have to do increased screening for the patient if you think that the patient can develop. And in case of dyslipidemia, you can give statins and all that and control dyslipidemia. So that is a treatment in case of stage A. Next, when it comes to stage B, what do you? If they are pre-diabetic, I mean, if the stage is called as pre-heart failure, right? So any treatment will you give? What do you think? So it depends, yeah. So if you find a patient who is having, if the patient is not having any signs and symptoms, but if you've done echo and if you find that the patient is having less than 40 or if he's having reduced ejection fraction, you can start the patient on ACE plus beta blockers, okay? ACE plus beta blockers. Okay, if you find the patient is less than 40%, you can start the patient on ACE plus beta blockers. In case the patient is not tolerating ACE, can you tell me the common side effect of ACE inhibitor? Dry cough. ACE, it is more common with angioedema, all that. So then, and you can switch the patient to ARBs. So can you tell me the common side effect of ARBs? Hyperkalemia is the common cause of ARBs. So you should always close monitoring of potassium levels is recommended with ARBs, whereas ACE you'll have to see for the dry cough and all that. Okay. And plus beta blockers is a mandatory. So beta blockers, will you go for cardioselective or non-cardioselective? Cardioselective. Example? Metoprolol, carvedilol, bisoprolol, all that. Okay. So that is when you find a patient with ejection fraction less than or equal to 40% with no signs and symptoms of heart failure. If you find a patient with recent MI and if his ejection fraction is less than 40%, what will you prefer? Same. You'll have to go with either ARBs or ARBs, any one according to the tolerance, plus beta blockers, plus statins, because they are highly prone to develop next plague, right? So to prevent that, you can put the patient on statins. Okay, so 3, that is ARBs or ARBs plus beta blockers plus statins. Next, if you find a patient with ejection fraction less than 30%, and if you think that he's got 1 year survival rate and survival rate post MI, so again to calculate that survival rate, you'll have some standard calculations, you'll have some standard scales. So, and if you find that the patient is having ejection fraction less than or equal to 30% with greater than 1 year survival, you'll have to put the patient, you can do this procedure called as ICD. That is insertion of a pacemaker, okay, ICD. So that is because to prevent the patient from sudden cardiac death. So that is why it is preferred to put the patient on ICD. So what is the criteria for you to put that patient on ICD? One is they'll have to have ejection fraction less than 30%. Then you see to that the patient, you will have to go with ICD procedure. Okay, that is insertion of pacemaker. Okay, now coming to stage C, that is symptomatic heart failure. First I'll go with HFpEF. So what is HFpEF full form?
Heart failure with preserved ejection fraction.
Okay, so heart failure with preserved ejection fraction. The first line agent is, first you'll have to put the patient on 3 drugs. One is diuretics. Why? Blood volume, decrease the preload. After that, you'll have to put the patient on SGLT2 inhibitor. That is dapagliflozin. Okay, that is again, it will help in increase diuresis and all that, and it is found to be cardioprotective. And third agent is, either you'll have to put the patient on ARBs or AC inhibitors or ARNIs, any one. Okay, imagine it's better preferred, first you'll start the patient on ACE. If it is not tolerated, you can go to ARBs, and in case again they don't tolerate, you can go to ARNIs. Okay, so that is best. Always you'll prefer ARNIs because the side effect is less because this is in high risk of hyperkalemia, which the patient can develop arrhythmias at any time. So it's always better if you put the patient on ARNIs. Okay, that is what is ARNI, you all know, sacubitril plus valsartan. Next, now the patient is having HFrEF. That is full form?
Heart failure
with reduced ejection fraction. Okay, so when you find a patient is put on heart failure with reduced ejection fraction, the first line agent what you'll have to start him on is diuretics. After that, ACE or ARBs and beta blockers. So these 3 are compulsory. Okay, this is your first line agent. These 3 should be given to the patient at any cost. So ARBs, so diuretics can be loop diuretics. You'll have to start the patient first on loop diuretics. That is furosemide 20 to 40 mg OD or BD dosing, or torsemide 10 to 20 mg OD dosing. Okay. Next, in case if you find the patient needs better, in case you want to increase the dose of furosemide, instead of increasing the dose of furosemide, you can withhold 20 mg OD, and you can add something called thiazide diuretics. Okay, among thiazide diuretics, which is preferred is, we have 2 types of thiazides. One is thiazide diuretics and thiazide like diuretics. So we prefer thiazide like diuretics, that is metalazine 5 mg. Okay, metalazine 5 mg OD. Okay, or 2.5 mg BD. You can add on. Next, coming to AC inhibitors, examples. Examples is captopril, enalapril and lisinopril. These 3 are more preferred. So captopril, it is 6.25 mg TID can be given. Next is enalapril 2.5 mg BD or lisinopril 2.5 to 5 mg OD. So this is the dosing. And next, when it comes to ARBs, can you tell me examples? Okay, so we prefer 3 types of drugs in heart failure patients. That is losartan OD, candesartan, it is 4 to 8 mg OD, and valsartan, it is 20 to 40 mg OD. Next, coming to beta blockers. So beta blockers, examples. Okay, so bisoprolol 1.25 mg OD, metoprolol 12.5 to 25 mg OD, and carvedilol 3.125 mg OD. So carvedilol is known to have both beta plus alpha blockade, so that is why it is more preferred, okay, in heart failure patients. Okay, so once you put the patient on diuretics, all these 3, if you find that the patient is still having persistent symptoms, and if you find that if the LV function, that is the ejection fraction, is going less than, if you find that it's now 35%, then you'll start the patient on aldosterone antagonist. Okay, then you'll start the patient on aldosterone antagonist, which is either spironolactone or eplerenone. Okay, so the dose of spironolactone is found to be 25 mg OD. 25 mg OD is the dose of spironolactone. Okay. Next, after this, still if you find the patient's symptoms is signs and symptoms is worsening, then you'll have to see if the patient is tolerating ACE or ARBs. If the patient is not tolerating, you can switch the patient to ARNIs. Okay, so that is a combination of sacubitril plus valsartan. So there is 2 combination. First, you'll have to initiate the patient on sacubitril 50 mg. Okay, that is 24 mg of sacubitril and valsartan 26 mg. Okay, 24 mg of sacubitril and valsartan is 26 mg. So a total dose of 50 mg. Then you can switch to 49 mg plus of sacubitril plus valsartan 51 mg. Okay, so it is a total dose of 100 mg BD. Okay, so first it can be 50 mg BD or second it can be 100 mg BD. ARNIs. So there is three conditions. If you if you find that the patient is not tolerating AC inhibitors or ARBs, then you can switch the patient to RNAs. Okay. Next. Second, if you find that if you think that the patient's QRS is going above 120 milliseconds, then you can start the patient cardiac synchronization therapy. So this is something like addition of a pacemaker only. That is again that is to synchronize your rhythm. Yeah, that is why you will put that patient. So again, it is like a implant of pacemaker only. And finally, you have, if the patient's sinus rhythm or heart rate is going, if the heart rate is going greater than 120 beats per minute, then you'll have to start the patient on ivabradine. Okay. On ivabradine. So what is the mechanism of action of ivabradine? It acts as funny sodium channel blocker. Okay. So the dose of that is 5 mg BD ivabradine. Okay. So after all this, if you still find the patient is having persisting symptoms, then you'll have to start the patient on isoleucin, that is isosorbate plus hydroleucin combination, or digoxin, or you'll have to go for heart transplantation. Okay. Okay. So we'll just revise HFrEF. So the first line agent of HFrEF is first is diuretics, ACE plus beta blockers. If they still have persisting symptoms, then you'll have to put the patient on aldosterone. Still persisting symptoms, check if they're tolerating ARBs or ARBs, ACEs, ACE. If they're not tolerating, switch them to ARNIs. Otherwise, see if the QRS is going above 120 milliseconds, then you'll have to make the patient undergo cardiac resynchronization therapy. And if you find the heart rate is greater than 120 beats per minute, put the patient on ivabradine. Including, you should add on. Okay. And after this, still if you find the patient is having persisting symptoms, then you can put the patient on isoleucin or digoxin or heart transplantation. So that is about stage C. So we have two types, that is HFpEF and HFrEF. And finally, last one is stage D, that is acute decompensated heart failure. Okay. So for acute decompensated heart failure, once you diagnose that the patient is having acute decompensated heart failure, you'll have to see for two things. One, if the patient is having volume overload, or if the patient is having low cardiac output. Okay. If the patient is having volume overload, see what is the amount of volume overload. That is, if it is mild volume overload, you just have to start the patient on IV furosemide. Okay. IV furosemide. If the patient is having moderate to severe overload, you'll have to start the patient IV furosemide plus IV vasodilators, that is nitroglycerin. Okay. So that is the treatment algorithm in case of volume overload. Volume overload, mild overload, you'll start the patient on IV furosemide. If the patient is having moderate to severe overload, then you'll have to start the patient on IV furosemide plus IV nitroglycerin. Okay, nitroglycerin at the rate of 5 to 10 micrograms per minute. At the rate of 5 to 10 micrograms per minute, nitroglycerin. Okay, that is vasodilators. Next. That is one. That is if the patient is having volume overload. Second, if the patient is having low cardiac output, again you'll have to see. If they are having mild to moderate cardiac output and if the systolic blood pressure is greater than 90 mmHg, then you'll have to start on either of two. That is milrinone. It is called as PDE3 agonist. It is called as milrinone, or you'll have to start the patient on dobutamide. Okay. And if you find that the patient is having very low cardiac output, then you'll have to give inotropic support. So what are the inotropic support? That is, we have three types of inotropic support. One is adrenergic agonist, that is dopamine or dobutamine. Then we have PDE3 inhibitors, that is milrinone, or we have vasopressors, that is epinephrine and norepinephrine. So selection depends based upon the patient's condition. So among these, which is superior, it depends completely based on the patient. So it is individualized therapy. And after giving him proper inotropic support, then you'll have to start the patient on IV vasodilators, which is again nitroglycerin at the rate of 5 to 10 micrograms per minute. So this is a treatment of acute decompensated heart failure. So there is two criteria. You'll have to check for volume overload, or you'll have to check for cardiac output. Volume overload, low volume overload, mild, only IV furosemide, moderate to severe IV furosemide plus IV vasodilators, that is nitroglycerin, or if the patient is having low cardiac output and his volume overload is normal, if is having low cardiac output, see if it is mild to moderate. If it is mild to moderate, either give milrinone or dobutamine. If it is moderate to severe, first you have to start with any one of the inotropic support, which can be dobutamine, dopamine, or milrinone, or epinephrine or epinephrine, completely individualized. After that, you'll have to start the patient on IV vasodilators, that is nitroglycerin. So that's it about treatment guidance of heart failure.